Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, producer of Public Health on Call. Today, examining a claim in the Make America Healthy Again report from the Department of Health and Human Services. Specifically, the claim that there are no benefits to children from some common surgeries. We hear from a surgeon, Dr. Emily Boss, the director of pediatric otolaryngology at Johns Hopkins, and Dr. Boss speaks with Dr. Josh Sharfstein about tonsillectomy, adenoidectomy, and tympanostomy, otherwise known as getting your tonsils and adenoids out, and ear tubes. Let's listen.
Dr. Emily Boss, thank you so much for joining me today on Public Health on Call. We're going to be talking about a couple surgical procedures in children.
I can't wait. Thank you for having me.
Now, let's be upfront. The reason I gave you a call is that there was this report about making America's children healthy again that came out of the Department of Health and Human Services. And I'm reading along the report, and I noticed they took a couple swipes at surgeries that are relatively common in kids. One of them is adenotonsillectomy, when kids get their tonsils and their adenoids out. And the other is tympanostomy tubes, which are basically ear tubes, which also is a surgery that some kids get. And in the first case, they said that there was no benefit for getting your adenoids and tonsils out. And they wrote that there are many and often severe harms of this surgery, which they described as unnecessary. And then for ear tubes, they said it did not reduce infections in trials showing common surgeries cause harm without offering benefits. Dr. Boss, you read this too. Is that true?
I did read it, and I am so grateful for the opportunity to clarify some of the science and parent experiences of their children who have these surgeries.
Okay, well, let's start with ear tubes. So tell me about this surgery.
All right, well, let's do a crash course in ear infections and ear tubes. So kids get ear infections, which is usually a buildup of infected fluid or not infected fluid that happens behind the eardrum, and it can cause pain or fever, and that's a common kind of infection that we see in little kids. It's the most common reason kids go on antibiotics or go to a pediatrician, or it can be fluid that's not infected but hangs around and can cause muffled hearing or hearing loss and speech delay. And so a surgical treatment of these either recurring ear infections or long-term middle ear fluid that causes hearing loss is placement of ear tubes. And ear tubes are tiny. They're less than a tenth of the size of a dime. They are a surgical procedure performed under general anesthesia. It takes about 5 minutes and is largely uncomplicated. And so usually after ear tube placement, the fluid is drained. Children who do have recurring ear infections are able to be more easily treated with ear drops and not oral antibiotics. And then they also don't have the same symptoms of these terrible infections like high fever, fussiness, misery when they lay down, less missed work in school. And then children who have long-term middle ear fluid and hearing loss usually can hear.
So let's take those benefits one step at a time. A lot of kids get ear infections, but not all kids get ear tubes. And so, once you have one ear infection, you may treat that with antibiotics and the child gets better. Which are the kids that you would recommend to go on to this surgical procedure?
So, I'll just start by saying that I end up talking a lot of children out of ear tubes, and it's the same way that many pediatricians probably talk a lot of families out of need for antibiotics. But the children that we are really focused on are, one, children who have middle ear fluid that's lasting for longer than 3 months and can result in some other symptoms like reduced hearing, reduced learning, difficulty in school. Children who are at risk for speech or developmental delay, and those can be children who have other medical problems that also put them at risk of having these functional issues that can be exacerbated when a kid has middle ear fluid. And then children who have multiple recurring ear infections that cause symptoms, require antibiotics, cause missed school, cause intolerance to the medications.
So for these kids, if they're getting this surgery, you're going to expect that, for example, if they're having hearing trouble, their hearing would get better.
Yes, correct. Their hearing gets better actually instantly if they have middle ear fluid of duration longer than 3 months.
And you also would expect that their infections would be easier to treat. Would they get fewer infections as well?
They do get fewer infections, but the true advantage in the setting of recurring ear infections or recurrent acute otitis media is that the infections are easier to treat. The infections, when they happen, are better tolerated. Kids have less pain of having that fluid, the pressure of the fluid building up. Kids have reduced symptoms, and we don't need to use oral antibiotics. We can usually treat the infection with first line, at least with ear drops, rather than an oral medication.
So when you read that these tubes did not reduce infections in trials and didn't talk about the benefits potentially for hearing and as a result of hearing for language, how did you react?
I felt really sad because I think I know that there are many children, if we were to take that one assertion just at complete face value, there are many children who do have hearing loss that can be very easily and immediately resolved who would not get necessary care.
Well, let's move on to adenotonsillectomy, another common procedure. It used to be more common. Actually, ear tubes also used to be more common. But tell me about this surgery.
So adenotonsillectomy, that's removal of the tonsil and adenoid tissue. Tonsils and adenoids are lymph tissue that are in the back of the throat and the nose. The tonsils you can see, they're those big balls in the back of the throat. The adenoids you can't see in a routine exam, but they're in the same ring of tissue of tonsils. So one's a problem, usually the other is too, especially as the tissue relates to snoring or sleep apnea. So when tonsils and adenoids are enlarged in smaller airways of children, kids can have significant mouth breathing or disruption of sleep, which is it can be any spectrum of snoring, loud snoring, or pauses in breathing at night, which is a term for which apnea describes. And a common treatment, particularly for sleep disordered breathing or the spectrum of problems from snoring to sleep apnea, is removing the tonsils and adenoids.
And how well does it work?
It works wonderfully when it's performed on the right children. We've been talking about the necessity of tonsillectomy for decades. It's been the most common major procedure because it can have major side effects in terms of duration of recovery and pain and risk of having bleeding or need for reoperation, all of those which are improving with different techniques. But when done for treatment of sleep apnea, children really have huge benefits in sleep, behavior, paying attention, and general quality of life.
What are the kinds of studies that have demonstrated those benefits? How are they constructed?
I can tell you that there are truly hundreds of different reports and different types of studies that have looked at outcomes of tonsil and adenoid surgery, particularly in the setting of sleep disruption. The most well-recognized are these large-scale randomized controlled trials where scientists will put some children in the arm of having early surgery and others in the arm of having what's called watchful waiting, where we wait and see how the kid does and then see whether or not they benefited from not having surgery. It's still always an option to go either route. And the studies are really positive that surgery does result in benefit. Now, there are many children who have resolution of their sleep symptoms over time with watchful waiting, meaning no surgery. But there are also many children who really do need the surgery. And so to see a dismissal of the benefit of tonsil and adenoid surgery could, again, potentially just limit necessary care for children who are really struggling and falling behind with this problem.
What I hear you saying is these are surgeries, they can have adverse effects, they can have complications, but they also can have really meaningful benefits for kids. Being able to sleep, which is so important to being able to function well in school and socially and everything else, and being able to hear, which is really important to the development of language. These are not small benefits that are going to be on the other side of the ledger from the potential for harm.
This is really true. And if you talk to parents who are really probably the best advocates for this procedure, they will describe their children's problems with such emotion. They'll say, I am shaking my child at night. I'm scared my child's going to stop breathing. My child is falling behind in school. My child can't hear me. My child's not keeping up. So, and they will then describe, again, when we're choosing the right children for the appropriate indications, they'll describe the benefits of surgery as really transformative.
Yeah. Well, let me ask you it this way. This is not how it was presented in the report. The report was presented that there's basically no right time to do these surgeries. But what if they were making a slightly different argument, which is that not everyone is picking the right kids, that maybe there's some surgeons out there doing too many of these surgeries, and that for those kids, they're not actually perhaps getting the benefit, or the benefit isn't worth the risk that they're taking. Do you think that's a problem or a potential problem in this country?
Thank you for pointing this out. So I commend the MAHA Commission for addressing overuse and appropriate use of care. And this is something that I, as a physician and scientist, have studied very closely, making sure that we're performing surgery on children for the right reasons at the right time for the kids who need it and not for all kids. These procedures are performed so commonly that there is definite unnecessary variation in how care is practiced and how care is delivered. But that also should be coupled with, there's overuse in some kids, and then there are also some kids who likely aren't getting the care that they need. And so we want to proceed by having caution about appropriate use of care while also allowing for children with these problems of obstructive apnea or snoring or hearing loss from middle ear fluid to receive the care that they need.
In other words, if this report had said, we've got to do a better job at making sure that the kids who really need these surgeries get them to get these important benefits, you would have been all in.
Absolutely. And I am excited about curbing overuse and gaining more standardization of care practices. And that really involves multiple levels of strategy and approach that ranges from how surgeons are identifying the right candidates, how we're testing children, how our societies are reacting, and how our health systems are responding.
But in other words, it's not a great place to start by saying there's just something wrong with the procedures altogether.
Correct. And the claims about adenotonsillectomy said that it conferred no benefit in trials for children with sleep apnea, which is a false claim. The report does talk about the potential harms of surgery. And again, I feel strongly that our specialty and this procedure can continue to become friendlier so that we reduce harm while still allowing children to undergo it who need it.
Dr. Emily Boss, thank you so much for taking time to talk to us about these topics.
Thank you. Thank you for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.